Hello, everyone. Thanks for tuning in to the monthly Psychedelic Support Speaker Series. Today, we will be hearing about MDMA-assisted group therapy, including current clinical trial protocols, and examining how MDMA influences group dynamics and therapy processes. It's a pleasure to introduce Dr. Chris Stauffer, who is one of the few people in the world who has worked on clinical trials involving psychedelics and groups. Dr. Chris Stauffer is a dual board certified in psychiatry and addiction medicine. He is an associate professor of psychiatry at the Oregon Health and Science University, where he is a founding member of the Open Psychedelic Evaluation Nexus. He's also the director of the Social Neuroscience and Psychotherapy Lab, SNAP for short, which is housed primarily at the Portland VA Medical Center. And I'll drop some links into the chat after I finish reading the introduction, and you could look more into some of this work that he's involved with. It's really fascinating. He's also done clinical trial work, which focuses on combining social psychopharmacology like oxytocin, MDMA, and psilocybin with psychotherapy to treat PTSD and addiction, including several group therapy trials, which we'll be hearing about today. He is an investigator on a phase 3 trial of MDMA-assisted psychotherapy for PTSD, as well as a study on psilocybin with group therapy for psychological distress in long-term survivors of HIV/AIDS at UCSF. So welcome, Chris. Thanks so much for being here.
Thank you so much, Ali. It's great to be here. I see some familiar names in the chat already, so that's great to see. So just some disclosures. So I did do psychotherapy training for MAPS, now Lycos, between 2021 and 2023. And the funding for this trial that I'm going to talk about comes from the Stephen and Alexandra Cohen Foundation, the Dr. Bronner's Family Foundation, and we do get our MDMA, our study drug, from Lycos. And so just starting broad scope, so thinking through, the process of gathering in groups with a healing intention and entering into non-ordinary states of consciousness is really a universal human phenomenon. It spans time and culture, and this is both with and without psychedelics or MDMA. And you can see in the pictures here, group healing comes in lots of different forms. We've got religious or sacred ceremony. We have the whirling dervishes, so like movement, dance, holotropic breath work. We have a picture from a rave or a music festival, different retreats or psychedelic services, and then we have individual and group therapy. And you can see from second to the right on the bottom with Marcella and Bruce, who are MDMA therapy trainers, that the sort of standard in the field, at least in clinical research, is to work with co-therapy dyads, which to me is already a small group. I think different things can happen in a group of 3 compared to one-on-one work. And MDMA is interesting. It really doesn't have indigenous roots. We know it entered into the psychotherapy space in the 1970s. It also entered into the dance scene in the 1970s, and really found kind of a cultural spot in music festivals, raves. And interestingly, researchers have looked at things like the electronic dance music scene and found that a high percentage of people do associate these experiences with well-being, and even spiritual experiences. And some substances are negatively associated with well-being, but MDMA is not one of those. Another interesting sort of tidbit of history for MDMA specifically, when the field was debunking the misinformation from studies saying that MDMA was neurotoxic, and then that information was spread by our own government that MDMA made our brains look like Swiss cheese. It was actually challenging to find people, like a population to study of people who used MDMA frequently but didn't also use lots of other substances. And so data from polysubstance users was being extrapolated to describe the effects of MDMA. But John Halpern from Harvard found a sample in Salt Lake City where, the use of alcohol and tobacco was culturally taboo. But MDMA hadn't really explicitly been condemned, so it was kind of one of those Mormon loopholes. And so there were some people who would go to these dance or festivals and only use MDMA and not other substances. And so they were able to study a sample of non-users, moderate users with 22 to 50 lifetime uses of MDMA, and heavy users with 60 to 450 lifetime uses. And they didn't find much of a difference between the non-users and the moderate users as far as cognitive functioning. But they did find some differences reflecting poorer functioning in heavier users. And so it's, I think, just an interesting piece. I'm actually from Utah. I was not one of those ravers, but I think it's an interesting piece of history. And so this is a quote from Eric Byrne from his 1966 book on group therapy. The knowledge of group dynamics for a group leader is as essential as knowledge of physiology for a physician. And Eric Byrne, interestingly, was influenced by Timothy Leary, who, before he got into the psychedelic field, Timothy Leary wrote his dissertation at Berkeley on the social dimensions of personality, group structure, and process. And he reflected that during that time, and this kind of tongue-in-cheek, but he said a medically trained psychiatrist considered group therapy as recklessly dangerous as requesting a group of patients to perform perilous surgical operations on each other. And this was in the 1940s. And so there really has been a lot of development in how we think about and how we run therapy groups over the past 100 years. And there's lots of different models, lots of different theories on group dynamics. Maybe coincidentally, maybe not, during the time when early psychedelic research was happening, there was a lot of development in the psychoanalytic world, exploring the unconscious and the psyche, which expanded into group theory. And so Wilfred Bion was a British psychoanalyst, and he published this book, Experiences in Groups, in 1968. And he was reflecting on his observations of group dynamics and how unconscious processes can shape group functioning. And so this is like the most high-level overview of Bion's, I think, really poetic and nuanced work. But he identified three basic assumption modes that groups of people tend to operate in automatically. The dependency mode, which is more of a primitive state of functioning where the group looks for a leader to kind of take control and problem solve and provide security. And this can lead to sort of groupthink in a way that stifles creativity or independent thinking, which can impact desired outcomes. This mode doesn't really tend to foster group cohesion or group meaning. Fight or flight, attacking perceived threats, either outside of the group or a threat within the group, or avoiding challenges and conflict altogether. That's kind of fight or flight mode. And members can exhibit sort of competition, conflict, hostility, defensive-ness. And these are really very natural processes in a group, but they can also hinder group cohesion and productivity. And then pairing is another type where the group collectively starts to hope that either like a savior or maybe the uniting of two members will generate new ideas that will solve the group's problems. And so with the basic assumption groups, unconscious emotional needs sort of dominate behavior and divert attention. But Bion then talked about work groups where the members are focused really on achieving a task in a rational and more mature way. And it's certainly not a linear path for a group to become an effective work group. And in a therapy group in particular, the therapist can sort of help make the unconscious group processes that might be distracting conscious, and can gently redirect the group back toward engagement and group goals and build cohesion and flexibility. And then piggybacking on Carl Jung's work, Bion talked about groups developing a collective unconscious, sort of the sum is larger than the whole. In therapy, this means that individuals might act in ways that reflect the group dynamics rather than acting on personal issues alone. We can get into sort of archetypal roles that extend beyond the individual. And then Bion also introduced the idea of containment, which is a word we talk about a lot when we're working on our group MDMA study. and sort of the ability of the facilitators to hold or manage the anxieties or the more challenging emotions of group members. And really, I think a good group facilitator can process anxieties and emotions that may be less than tolerable for the group, and then return this material to them in a more digestible form, which is often what we do in individual therapy too, but it's more of a group process. And today we know a lot more about group dynamics in a therapeutic sense and group psychotherapy, in no small part due to the work of Irvin Yalom. His book, Theory and Practice of Group Psychotherapy, first published in 1970, and now it's in its 6th edition. I've heard a lot of colleagues refer to this as the Group Therapy Bible. And through the decades, he has refined these 11 factors that he believes are unique in affecting change through group therapy versus individual. So things like group cohesiveness, the feeling of belonging to a group, and valuing the group. And Yalom's sort of group cohesiveness is different from group cohesion, which we'll talk a little bit about later, and I'll define that a little bit later. But other things like instillation of hope, encouragement that recovery is possible by sharing and witnessing people at different phases in their healing journey, universality, essentially knowing that your problems aren't unique, that you're engaging in sort of a shared experience, just imparting information, altruism. I think my favorite one is corrective recapitulation of primary family group. And so really we're kind of recreating family dynamics in this group setting, which you can't do as much in one-on-one therapy, a little bit, but not in a sort of family system sort of way. And then once that's happening, there's room for having corrective experiences. And interestingly, this is total coincidence, but a friend of mine lives next to Irving Yalom's granddaughter, and their kids play. And so she was able to connect me to him, and I shared some emails with him about this MDMA group study, which is kind of a cool phenomenon. And so what is group therapy nowadays? So typically group cohorts are 4 to 12 participants. They're often co-facilitated by a dyad. When training therapists in the MDMA model, I often hear that the only other times that they've worked in a co-therapy dyad is when facilitating groups. But when we talk about group therapy, it really encompasses a wide variety of different things. And so some helpful ways to sort of think about different types of group therapy are thinking about open versus closed. And so open groups are more like drop-in groups or groups with rolling admission. So as people become eligible, they just add the group, and some people leave the group. Versus closed, which is the same pre-selected group of people throughout the entirety of the group. There's also open-ended versus time-limited. And so open-ended is more long-term, more sort of Tavistock or Yalom-esque kind of process group, can be more open-ended, versus a time-limited group, which is primarily what we do at the VA, like a 12-week CPT group, a cognitive processing therapy group, for example. And then as far as modality, I think there's lots of different types, and they tend to fall on a spectrum. So there's sort of psychoeducation groups, which can be more like classroom style with a facilitator sort of teaching psychosocial skills or mindfulness practices with less interaction among the participants. And then we have support groups. Oftentimes support groups are peer-led, or led by someone with lived experience of the issue at hand, with more of a focus on providing emotional support to each other, offering practical advice or different coping strategies. And so thinking of like an AA group would be more of a support group, versus a therapy group, which is usually facilitated by a mental health professional. They usually use a specific modality or some sort of manualized treatment to address specific psychological issues. And then with the professional facilitation, the group's usually able to explore more deeply, delve into more of the interpersonal dynamics, and ideally affect some sort of therapeutic change. And the length of a therapy group, so whether it's it's open-ended or limited to 12 weeks, whether it's the same participants versus open or drop-in group, tends to determine what the modality is and sort of how the group functions. And so think about a 12-week cognitive processing therapy group. You want to make sure that the participants in the group are already bonded together by some sort of shared experience. So you can begin the group with a sense of cohesion because you don't have a lot of time to develop that. And so thinking about the psilocybin trial, the psilocybin group therapy trial that I worked on with Brian Anderson at UCSF, we worked with long-term AIDS survivors. So they have a very specific shared experience. And then for our group MDMA study, we're working with groups of veterans. And so we have combat veterans and veterans with military sexual trauma in separate group cohorts. You also want a fairly structured container for a 12-week group. I'm also thinking of something like a weekend retreat model with psychedelics, where there's maybe more psychoeducation, maybe some sharing circles, but the facilitators are heavily facilitating in order to sort of keep the group on track and not get too thrown off by group process. Versus a closed, open-ended group is the same people over an indefinite period of time can tolerate, a more diverse cohort of people, different diagnoses, maybe even like wider demographic range. And you have more time to let the group process figure itself out. So there's a little bit more tolerance for conflict to emerge and be examined slowly over time. This is more similar to what you'll see with the Swiss MDMA groups that I'm going to tell you about in a little bit. It's more of a longer term over several years. The AGPA, the American Group Psychotherapy Association, has some great resources, including guidelines for kind of all phases of the group, thinking about how to assemble a group, cohort, group processes to be aware of, ethical issues unique to groups, all the way to considering about termination of a group. And I think the guidelines on the website are from 2007, but they're actively updating them right now, so they should be revised soon. And I'm actually looking forward to, I'm going to be presenting probably a fairly similar talk at the AGPA annual meeting in San Francisco in March. And then I guess thinking about group therapy kind of today, so most psychiatric disorders, group therapy has been shown to be at least equally as effective as individual therapy. Of course, PTSD is a little more complicated. Essentially, there's no group therapy for PTSD considered evidence-based. This is according to the 2023 VA Department of Defense Clinical Practice Guidelines for PTSD, which really are the highest standard of PTSD care. And here they talk about how there's insufficient evidence to recommend for or against any specific group manual. Also in the guidelines, they essentially say that group therapy is better than no therapy or a waiting list, but not necessarily shown yet to be better than individual therapy. And there's no evidence to recommend using it as an adjunct to people who already have individual treatment. That being said, group therapy is widely used in places like the VA, including for PTSD. And so these sort of non-specific recommendations are more of a reflection of the limitations of kind of what's in the scientific literature on group therapy for PTSD rather than what's in actual practice. But existing studies really highlight two primary types of efficacious group therapy for PTSD. There's trauma-focused group therapy, which generally includes some form of like directive trauma exposure or cognitive restructuring, like the cognitive processing group therapy for PTSD. And then the second type is present-centered group therapy, which interestingly started out in research as a control condition for trauma-focused group therapy, but was found over several studies to have comparable efficacy and lower dropout than when you sort of manualized direct trauma exposure. And so this modality is now sort of considered effective for group PTSD treatment. And it has more of a here and now focus on current PTSD symptoms, what's going on in the room, emotion regulation, kind of teaching others coping strategies and skills without delving into specific trauma memories. And so now we'll get into sort of what happened in the early days of MDMA, when MDMA was paired with psychotherapy. This sort of thinking of these two different main approaches that emerged during the 70s and 80s comes from Ralph Metzner. And this was, in clinical settings legally, that the first type was sort of parallel individual groups run similar to how we would run like group holotropic breathwork, or which holotropic breathwork heavily informed the individual MDMA manual, or thinking about an ayahuasca circle where it's typical for participants to sort of be restricted to their own mats and instructed to interact only with a therapist if they need support. And Leo Zeff, who trained more than 150 MDMA facilitators and I think facilitated thousands of sessions in the 70s and 80s with MDMA, has this quote here: "Sometimes people like to get up and do some hugging, and then we set them right back down." And so Zeff preferred individuals engage more in this inner-directed work during MDMA sessions in a group, and then would come together in a circle afterward. And this is the model that we chose for our group MDMA study, which I'll talk more about in a little bit. But the second main approach is one in which the group interacts during the MDMA session. And one is more structured, and this involves like a tighter frame. Participants are either sort of sitting or laying in a circle and tend to maybe talk one at a time. And so sometimes there's a talking stick, so that the group doesn't break up into multiple conversations or subgroups. And then another type involves more non-directive, unstructured interaction. And this is the type of group that Claudio Naranjo, who's a Chilean psychiatrist, preferred. And he talked about how the group would become a spontaneously organizing system, and that things would sort of spontaneously and organically happen that he could not have directed or predicted. And this type of group specifically tended to be done with participants with pre-existing and ongoing relationships. And so, family members, friends, coworkers, and then of course during these sort of types of groups, they always had the option to withdraw into a private space if needed. But otherwise the group was together and interacting. And then just to comment on what's been going on in Switzerland. So when the rest of the world experienced MDMA prohibition after it was made into a Schedule I substance in 1985, the Swiss government allowed for restricted medical use of Schedule I substances in cases of treatment resistance to standard treatment options. And Peter Gasser, Peter Owen formed the Swiss Medical Society for Psycholytic Therapy. They did 2 pilot studies from 1988 to 1993 with almost 200 patients in groups. And then starting in 2014, they've treated over 50 individuals clinically with special permission, probably well over 50 at this point. And they explored different variations of group therapy. Typically, they would do groups of 4 to 8 people. I think earlier groups were up to 15, with dosing sessions a couple of times a year. But the group would continue to meet regularly in between dosing sessions and across several years. So this would be, considered more of a closed, open-ended group. And the majority of their group therapy patients have complex PTSD, dissociative disorders that are treatment resistant, and they suggest that this type of like complex PTSD, dissociative disorders that are harder to treat require a larger number of psychedelic sessions over a longer period of time compared to the more single incident PTSD. And some of their groups were administered just MDMA. Others used MDMA for the first 3 or 4 sessions to sort of engage the patient, strengthen therapeutic alliance, get some emotional regulation skills among the group. And then they would switch to LSD, 100 to 400 micrograms, to deepen into the therapeutic process. And this isn't to say other MDMA groups weren't happening around the world, but the Swiss group was able to do this more systematically and write about it, which really makes it the only sort of standardized model that we've had since the 80s. And so now to discuss the protocol for our study at the Portland VA. I guess first, just thinking this has been a really circuitous journey. I started developing this protocol with Brian Anderson and Jenny Mitchell at UCSF in 2019. And the goal at that time was to do this study at the San Francisco VA. But I got a job at the Portland VA. I moved here in 2020 to start a psychedelic research program. And this was my parting gift from Brian and Jenny to say, they said, take the group protocol and see if you can do it at the Portland VA. There were lots of minds sort of considering the design of this trial, a lot of input from Michael Mithofer, Allison Coker, Jess Lynn, and Shannon Prawl. And I'll walk through the protocol now. So we have our very first session is a group preparation session, and this is after all the screening and enrollment happens. And we are doing groups of 6 participants with therapy teams of 4, which I'll talk about in a little bit. So the preparation period has 3 group preparation, and then each individual person has their own individual preparation between group prep 2 and 3. And that prepares them for their first MDMA session, which is individual, with an individual integration the day after. And then all the rest of the visits are group. And so we have group integration. The second MDMA session, about a month after the first, is a group MDMA session. And then more group integration. And then about a month after the final integration, we have their assessment where they get their PTSD symptoms evaluated. And for our 4th and final cohort that we're moving through the study right now, we were actually approved to add a 3rd treatment cycle. And so they have a second group MDMA session and 4 more group integration sessions. So that'll be interesting to see as well. More match the phase 3 individual study design. And here's a panoramic photo of our group therapy space at the Portland VA. This is how it's set up for group dosing. This is also where the group prep and integration sessions happen. Obviously, very different setup for those sessions. And then we have individual treatment rooms for the individual sessions. But you can see here we have the circle in the middle with backjacks. That's where we start the dosing days before the dosing happens in circle. And that's where we end the day in circle together. And we have a system that plays music from the speakers as well as in individual wireless headphones that each have their own volume control. And here's our great team. So I learned MDMA therapy from Michael and Annie Mithofer and from Bruce and Marcella in Boulder, who are both married couples. And so when we were preparing our co-therapy dyads for phase 3, we spent a lot of time getting to know each other, getting to know each other's strengths, our growth edges, and just really strategize about how to collaborate in the therapy room in these really intensive 8-hour sessions. And so when we started to put our team together for the group study, that was kind of an exponential sort of, we needed to have team cohesion rather than just co-therapy cohesion. So we spent a lot of time together. We went kayaking as a group. We did karaoke together as a group. And we had multiple people in the lab get trained to do MDMA therapy, but we spent a lot of time figuring out who would work well together, whose skill sets would complement each other on teams of 4. And I'm really proud of how interdisciplinary our teams are. So represented here, we have psychiatry, nursing, psychology, social work, counseling, chaplaincy, art therapy, holotropic breathwork facilitation and training, and we also have veteran peer support specialists. And our model was really sort of developed to counter the hierarchical power structure of the military into a more egalitarian stance. And that's how we spent a lot of our group preparation, is modeling that. And one of our clinical supervisors who reviews session videos commented that he never noticed a sort of typical biomedical hierarchy where the MD was the expert and the peer counselors were support staff, and that was intentional on our part. And so it was nice to get that acknowledgement from our clinical supervisors. And for this study, so each cohort is facilitated by a team of 4. All 4 therapists were present in the very first group prep, the group MDMA session, and the integration day after the group MDMA session, and then again at the final integration session. Otherwise, all the sessions were conducted by two therapists. And basically, it would be like the same two therapists for each individual person's individual sessions, and generally the same two therapists for the group facilitation. And so here are our teams, team for cohort 1, cohort 2, cohort 3. And you can see that there was always at least one person from the previous team on the subsequent team to pass on any helpful knowledge to the new team. And so we recruited our participants primarily through word of mouth from therapists at the Portland VA PTSD clinic and the Portland Vet Center. All of our participants were US military veterans. They had a charted diagnosis of PTSD, and our criteria for enrollment, they had to have a score of 33 or more on the self-report PCL-5, but we didn't do the CAPS before enrollment, just the PCL and a charted diagnosis of PTSD. They also had to identify a trusted support person. This was one of the first studies where we were able to send people home after their session rather than having them stay overnight in the hospital. And so we did trainings with the support people, which was essentially the same training that the night attendants would get in the studies where people had to stay overnight. And so we had a chance to sort of meet and orient the support person to what the evening would look like, and they would come and pick the people up after their MDMA sessions. We required that they had a stable living situation, be medically stable in general, no psychotic disorders, bipolar 1, no severe alcohol or cannabis use disorder. They could have moderate if it was not within the last 3 months, and they could have mild alcohol or cannabis use disorder for this trial, but no other illicit substance use disorder. And it was pretty lenient as far as suicidality. A lot of people had suicide attempts in the past, active suicidality, but no suicidal ideation that would require hospitalization or that was likely to require hospitalization in the short term. And then if they were not able to taper off of their psych meds. And then thinking about sort of veterans, a squad has 4 to 6 soldiers. Our cohorts had 6 participants. And so we were really thinking about how to translate some of the things that veterans learned in their military training to apply to healing and protecting this sort of group space that they were co-creating together. And here's the demographics for our participants. We've enrolled all 4 cohorts at this point. 42 years old on average, diversity of genders and sexual orientations. The race reflects the demographics of the Portland metro area. And our sample demonstrates veterans essentially who are not just sort of the stereotypical white heterosexual cisgendered man. You can see that most of them were combat veterans. About a third had a history of military sexual trauma, and some of them had both. And so we've enrolled 23 people across 4 cohorts. Our first cohort was people with a history of military sexual trauma, women and non-binary participants. And our second and third cohort were men with combat-related PTSD. And then our fourth cohort is a group of transgender, gender-diverse veterans, and they have a mixture of military sexual trauma and combat trauma. And 3 of their facilitator team identify as gender-diverse. The other used to run the LGBTQ veteran support group at the Portland VA. So we did a focus group a few years ago with transgender, gender-diverse people and asked them for feedback on the MDMA-assisted therapy protocol, and we took in their feedback and applied it to this cohort, which includes having a team of therapists that reflects the participants. So our outcomes, our primary clinical outcome is the CAPS-5, the clinician-administered PTSD scale. I think that's what it stands for. But essentially, we did that after enrollment, after medications were tapered, and between the first and second group prep session, and then the follow-up for that was 1 month after final integration. So they ended up being about 16 weeks apart with a 12-week intervention in there. Our CAPS assessments were conducted by a centralized rater pool, and they're blinded to the study design and the time point compared to the intervention. In between the CAPS assessments, we also did the self-report PTSD checklist from DSM-5 just to track PTSD symptoms. And so I think end of the preparatory period, and then about 3 or 4 weeks after each MDMA session. So we have those data as well. The SDS is the secondary clinical outcome from the MAP studies as well, the Sheehan Disability Scale. We're also measuring depression symptoms, attachment insecurity, post-traumatic growth, a really cool measure of group cohesion. We're looking at treatment expectancy, which was, phase 3 studies were criticized for not measuring this. And interestingly, in a preliminary analysis, it looks like this study is actually on par with what we generally see in mental health treatments. I think we happened to be conducting this study when the FDA made their decision in August. So, maybe some of the earlier ones were bringing in some hype, but then we kind of are in this trough of disillusionment. We saw the media change, and this is kind of an example of groupthink in the culture. But yeah, I think the hype is not the same about MDMA therapy as it was 6 months ago. And then finally, we're using a self-report measure of perceptions of touch that occur in the session. And I created this with Jason Luoma, Veronica Gold, and Emma Knighton, who's one of our study therapists, actually conducted consent and touch workshops with all of our therapists, so we could standardize our team's approach to consent around touch and how we provided supportive and therapeutic touch during sessions. So it'll be interesting to see. This is one of the first studies that this measure will be used for. And then we have our final CAPS assessment outcomes for our first 2 cohorts. So this is the first 12 people of 23. So you can see there was a significant reduction. And this does include a few people who were non-responders. So this treatment doesn't work for everyone, but you see a large reduction. This is, I think, an effect size of 1.83, which is on par with the individual after two MDMA sessions. Some other outcomes that I just want to mention, these are a couple of our STAR PhD students in the lab. Philip has added measures of epistemic trust, which is how much you can sort of trust information coming to you from someone. And he's pairing those data with really interesting attachment insecurity data, and is looking forward to sort of delving into the really interesting literature around that. He also added a measure of group synchrony, and so it's kind of looking at the extent to which a person feels absorbed into a collective experience, and they feel that out after the group MDMA session. And then he's looking at any changes in spiritual transcendence. And then Jenna is looking at emotion regulation as an outcome different from PTSD symptom reduction, and also at inflammatory markers before and after the intervention. So it'll be really interesting to see if there are any changes there. And now I just want to take some time to sort of talk through some things that we learned and are continuing to learn just from conducting these groups. I think there are some things, just my reflections of doing this work with individuals versus with groups, that there are certain things that take on or need special attention when we're working with groups. And one is consent. And so, like any clinical trial, we conducted informed consent individually with each person prior to screening. But we really consider, in any of these studies, consent to be an ongoing process that really applies in multiple ways. Starting with something as simple as psychoeducation, when we're talking about just the basics of set and setting and developing intentions, primarily during the preparation period. We use a motivational interviewing technique, elicit, provide, elicit, where we're eliciting consent to give information, and then we're providing the information, and then we elicit their reaction. How does that sit with you? And so we're trying to be really explicit when we're giving information versus when we're just holding space for the group to process. And then, of course, consent around touch is really important and something that we thought a lot about. And then also for people who have a history of spiritual abuse or harms within organized groups, even something like a group mindfulness exercise, which we, often just sort of go into, or we invite folks to close their eyes or, use our voice to talk them through a guided meditation. We actually get consent from everyone in the group, and we're open to the possibility that we might not, in which case we'll always meet the group where they're at, even if that's just working with diaphragmatic breathing or something more simple, and kind of moving towards something more complex. So being extra aware too of peer pressure and groupthink by noticing how engaged each person is in the consent process. And then bringing in Bion's term container. So setting and holding the group container is really the job of the facilitators. And you can't be non-directive about that. I think that this involves establishing safety, establishing a structure and a supportive environment that feels safe enough for participants to be vulnerable with each other. And the facilitators really set the tone, and I think need to stay attuned and intervene when necessary to facilitate group dynamics. In the first group session, right after introductions, we set group guidelines. And that kind of moves into the next item is we co-create group guidelines, and we really ask those guidelines to come from the group participants themselves. And if they don't get to everything that we think should be a group guideline, we use elicit, provide elicit, and suggest what we think. But I think it's usually much more rich conversation when you let the group sort of take the lead and start to co-create their own container. That's kind of manifested in different ways for the different cohorts, but it's an interesting, like the standardization is what's coming from the group rather than a more manualized approach. And then group cohesion. So this is kind of like the group version of therapeutic alliance. So there's really three main things that make up group cohesion. There's an agreement on the goals, agreement on the methods for achieving those goals, and then trust. And so not just trust between the participants and the therapists, but among the participants themselves, and then thinking about the group as a whole. So the facilitators and the participants, all of them. And like therapeutic alliance with individual therapy, group cohesion is linked to more positive therapeutic outcomes. And so this is something we're going to be measuring. And then just some challenges to consider in the group psychedelic setting. Something that I've noticed both in the psilocybin trial with groups as well as this MDMA trial is the tendency for participants to, come back from their experiences. In our psilocybin trial, they had individual psilocybin experiences. In this, their first MDMA is individual. But to come back and to start to compare their experience with others' experiences, and especially for people with a lot of self-criticism, you start to hear a lot of, oh, why didn't I have that experience? And it can kind of go both ways, like I've seen in the same group where someone who maybe had a really beautiful transcendent experience saying, well, why didn't I like go through hell and like process a lot of trauma? I feel like I should have done that. And then the person who went through hell and processed a lot of trauma is like, why didn't I have a beautiful transcendent experience? And so I think it sometimes requires a lot of preparation, but also the facilitators to sort of be curious about that phenomenon and try to get people to sort of stay in their own process and knowing that their own process is what was maybe needed for them. And they can learn and take in others' experiences, but to not automatically discount the experience that they had. And kind of along those lines, it's I think a phenomenon that we see on social media a lot where things the group mind starts to polarize things into, good or bad, right or wrong. And so, a group might automatically start to say, oh, like staying inside the whole time and having your eye shades on is good. And if you need support and you need to come out and talk, that's not good. And the group will start to kind of develop these group norms automatically. And so again, it's the facilitator's job to kind of express curiosity about that. Is that actually something that's true, or can we see some of the gray area in between and kind of find value in both of the polarities and as well as everything in between? And again, it kind of goes back to Bion's sort of the natural tendencies of groups and group therapy, really having skilled facilitators to come in and facilitate the process. Compromise is another challenge, and this is, can be really just basic logistics that you're compromising individual time and attention, in a group session. It's not focused solely on your process. You're sharing time with the group members. And it has its benefits, thinking of like Irvin Yalom's different factors. Our study protocol also had the flexibility to add individual integration sessions if needed. And so that'll be interesting data to look at how many people requested that and what that looked like, what those needs looked like. And then conflict within a group. I think, conflict can be really productive and really healing, just like the rupture and repair process in individual work. But it needs to be carefully facilitated in a group. And, rupture that isn't repaired can have negative consequences, but conflict in a group is a totally natural and normal thing that we can work with. And I think we just have to have careful facilitation around. And to kind of deepen into that thought, it is really natural for a group to have these different processes. I see one of my primary functions as a group therapist to always be scanning the environment for these 3 warning signs. One thing to consider when you're assembling a group are what I've heard referred to as fault lines. And so they're not fractures yet, but they could be. And so, are you putting together a group of 5 men and 1 woman? If so, you're maybe setting up a scapegoating process before the group even begins. So 4 men and 2 women is better. I think ideal is an equal mixture of gender or all the same gender. And I think we have to be really aware of repeating power structures that might cause cultural harm in the group container. For marginalized communities, I think it's maybe not best to be marginalized in a healing space. And so that's why we did our cohort 4 as trans veterans, because I think to have 4 or 5 cisgendered people and 1 or 2 transgendered people were reenacting that sort of imbalance, and different power structures can start to come into the group. And I think, fault lines are potential ruptures, so is subgrouping, and that's something that might start to occur naturally in a group. And, usually it's innocent. It's, certain participants resonating with other participants over certain things. But it can also reflect sort of deeper concerns about personal connection, about status in the group. And subgrouping isn't necessarily worrisome, but it's always something to sort of bring to the group consciousness in ways that evoke curiosity rather than defensiveness. And one thing to also consider is what's going on outside of the group. We sort of encouraged our group members to connect outside of the group because there's so much isolation among veterans. Some groups discourage that, but others just sort of request that if people are meeting outside of group to bring anything relevant to the group back into the group space. And then we have scapegoating, which again is a natural tendency of any group. The term, the roots of the term are biblical, comes from the book of Leviticus, where a goat is selected to carry all the sins of the people and then is banished into the desert. And that can be the conclusion of sort of unchecked scapegoating in a group, is exile. And so members who are different in some way or don't conform to certain things are likely to become scapegoats. I think with complex PTSD, sometimes you have to watch out for kind of what we refer to in our group as self-scapegoating, people who it's sort of protective response before the group can reject them. They start to reject them separate themselves from the group. But essentially, scapegoating happens when the collective anxieties of the group or things that are typically socially unacceptable, like envy or shame or neediness, get projected onto one individual. And then the group instinct is to eliminate that group member so that the group can then become a utopia. And so this process, I think, usually doesn't persist if one of the facilitators can sort of bring it to the group consciousness. Sometimes the group corrects itself, just simply by bringing attention to it. Other times it needs to be more facilitated, so the group facilitators can sort of inquire about whether other members can own what the scapegoated member's being criticized for. So, the need for more attention or the fear of vulnerability. And if other members can't automatically link themselves to the person receiving that scapegoating energy, then the facilitators can find authentic ways to link themselves. And of course, scapegoating of the leader can also occur, and can even be considered a normal part of group development. It's often a lot for the facilitator to hold, but this is where it's really helpful to have a cohesive facilitation team. And then just wanted to comment, I teamed up with Elliot Marseille, who founded the Collaborative for Economics of Psychedelics at UC Berkeley, to do a cost effectiveness analysis of our group protocol versus individual. And we found that reduction in clinician time and cost was over 50% for this group model that we're using. And now we just need to learn more about efficacy. But I think if the group model is of similar efficacy as the individual model, then I think cost effectiveness would be a bonus. But I'm always really careful not to discuss this with people as the driving factor for doing groups. I really, really, truly believe that there are unique healing benefits to group, and that should be centered, and it shouldn't just be trying to get a bunch of people in the same space for cost effectiveness. And so I think this is something that's been helpful and has come up a lot. It's just how we think about trust in the inner healing intelligence with our participants with individual MDMA therapy. We also think about trust in the inner healing intelligence of a group. And there are lots of different schools of thought, like Bion or even like systems theory, chaos theory, that talk about how when you bring sort of the chaos of multiple individuals together, that you actually have predictable relational patterns that tend to form within a group, and the group navigates toward cohesive units. And so even though we have all these natural processes like scapegoating and competition within a group, we also have natural processes that are moving toward cohesion. And so just an important reminder that a cohort of 6 participants is not just 6 individual treatments. It's really larger than that. And there will be group process happening even when individual participants are inward. So even though we're doing sort of the parallel individual model for the group MDMA sessions, there's still a really active and rich group process happening in the space. And I guess just to end on this, this is one protocol that we're working on here. I think there's lots and lots of room to expand and explore different options. I think different populations, different indications, different teams should find the protocols that work best for them and the people that they're serving. Currently, there's an MDMA-assisted group therapy study in Israel, working with military veterans there, and they have different key differences in their protocol that I think it'll be interesting to see. The Australia government has funded a clinical trial of MDMA-assisted group therapy with flood survivors, and there's a few other groups on the brink of starting group therapy clinical trials, which is, I think, great for our collective knowledge of this modality, and we'll be able to see it expand and develop. And then just some thank you.
All right. And a big thank you to you, Chris, for this window into group therapy process and the first peek at the data from the MDMA trial. I have, yeah, we have some questions coming in. And while I'm opening them, I'm curious if you're collecting any qualitative data from your MDMA trial.
We are, yeah, we actually got IRB approval to transcribe certain sessions. So like for individual, we're looking at individual prep and integration, as well as some of the group prep and group integration, just because the way people talk about their experiences and the language they use is so different, even, from like if there's just a few days in between. So we're really interested in looking more at that.
Very cool. Very cool. Okay, we have a question from a participant who's wondering if you could share more about Irvin's thoughts in your emails about group therapy with MDMA.
I mean, it was interesting. He's I think in his 90s, and he thought that it was really interesting. I asked for a consultation to meet with him and kind of just talk through it, but he said he was in not great health and didn't necessarily have the time or the energy for that. So we just kind of briefly exchanged.
Okay, cool. Were any of your participants on SSRIs?
Yes. Um, we we did have to do tapers for a handful of participants.
Yes, it's contraindicated for SSRIs and MDMA to be given together because SSRIs can reduce the subjective effects. I answered this question about toxicity in the chat there. So I'll just go on to the next one. Dr. Penn gave sort of more of a comment here. He really appreciates your explicit consent part. When we talk about groups, that is quite important because there's lots of individuals to consider with the consent process.
Mhm.
So the next question here is, how do you address transference and countertransference that may arise during the dosing or prep sessions?
It's a good question. I think that's the work that we're doing and it's so case by case too. It's just what ends up coming up um, is very unique to each individual. And I think I sort of see transference and countertransference as tools. Um, rather than some sort of thing that's going wrong. But I think it's important for the facilitators to really be tuned into what's coming up for them and how the participants process or how they are making the facilitators feel is something that we talk a lot about in supervision and have a lot of discussion around, just so we can conduct these sessions in the most responsible way.
Great. So on that note, on conducting sessions, what was the process in which MDMA was used for the study, and how were they structured, non-structured as far as participant dialogue and therapist interaction during the running of the session?
Yeah, I mean, are they kind of asking about what was the framework around?
Yeah, was it all non-directive, or did you
Mhm.
have 30 minutes of drop-in at the beginning, then switch to something else?
Yeah, for the group MDMA sessions, we actually had a more solid sort of framework because it's going to be 6 people. We had to kind of set the container in a more structured way. And so for the first 30 minutes, there's sort of more, I would say, sort of ritual around, checking in, doing kind of intention sharing. Some of our groups, one of the facilitators did sort of a threshold ceremony where as people would kind of move into the group space, there was just a different kind of way of thinking about that space. And then usually we would, read a poem or something as the dosing was happening. And then the rest of the session was interdirected and we were kind of open to whatever came up. And then in the last 30 minutes, we would come back together and have a sharing circle and closing.
Awesome. And are you aware of any other trials that are including groups for psychedelics?
Yeah, the Israeli group, and I think they're about to do a larger study as well. And the Australia group. There's also a handful of psilocybin group studies happening. I know that University of Utah and Sunstone both did psilocybin groups after our long-term AIDS survivors study with cancer patients, and they're kind of moving more toward group dosing. So I think the Sunstone study had 4 people dosing at the same time in separate rooms, but they could hear each other. And University of Utah study had 4 people in the same space, and they actually turned the chemotherapy infusion center into a dosing room where they were all in the same space together.
Oh, wow. Cool.
And then in
Yeah,
Oregon Health Authority, kind of our psilocybin services here, there's lots of group work going on here as well.
nice. Is there a price discount on participating in group sessions there?
Usually, yeah, usually that's one of the benefits is accessibility.
Uh, I just wanted to mention too, I dropped in the chat, we have a directory on psychedelic support of community groups. So if you are looking for a group to join around integration or specific needs, you can search the directory there or add your group if you have one. Let's see what else we have here. Oh, I see we're a few minutes over. So,
Okay.
do you have time?
I have time. Yeah, yeah. I would just
Okay,
note
well,
that somebody also mentioned ketamine groups, which are happening in other studies.
oh yeah, very cool. Thanks for the link there. All right, we'll just ask one more question or 2 more questions and we'll wrap it up. Interested in what kind of support individual and groups receive during integration processing, the material from journeys that can cause intense disintegration or debilitation. So what type of support is offered?
Yeah, I mean, we're kind of basing it on the present-centered model. However, our group is open to it's sort of interdirected, including group sessions. So if trauma processing does come up, our clinicians are able to handle that, and that is something that's allowed in the session. And then you said something about challenges, or
Yeah, that was basically it. And a quick question to you about, was there a booster dose given with MDMA?
yeah, it was the same sort of dosing strategy. We did 120 and then a booster of 60 at an hour and a half.
Okay, cool. All right, and last question. Do you think group therapy has different risk profile than individual therapy, and different ethical issues, and how can you cope with these?
Yes, absolutely. I mean, I tried to touch on some of them toward the end. But yeah, group dynamics and some of the risks that come from that. I think, going back to kind of one of the earlier slides, the Eric Byrne slide, that really group facilitators need to have a good understanding of group dynamics and how they work to effectively and ethically facilitate a group like this. And I guess one thing I haven't really commented on is, the MDMA, adding an MDMA to a 12-week group really turns it into a longer term group, because group process will get magnified and accelerate, just like with individual MDMA therapy, the therapeutic process gets magnified and accelerated. We see that same thing happening with groups. So the facilitators really need to be attentive to group process, and it can be really quite intense sometimes, but I think, therapeutic and also has its own risks and challenges.
Yeah, so it just occurred to me, like, how do you prepare for this? Do you have specific training for facilitating groups?
We had a lot of really skilled group facilitators, and we had people at the Portland VA who were running a program that was group-based, where they were working with sweat lodge ceremony. So they were also experienced working with groups in non-ordinary states of consciousness. And so I think that helped a lot.
Uh-huh. Awesome. Maybe you should put together a training on how to run groups.
That'd be great.
Yeah. All right. Well, we're going to wrap it up. So thanks so much, Chris, for being here. This was an enlightening presentation you gave, and I appreciate the audience too for tuning in. We're going to share the video and the links shared in an email follow-up. And we hope to see you here again at the Psychedelic Support Speaker Series.
Excellent. Great to see you, Ellie.
Yeah, great to see you, and take care, everybody.